Assalamu alaikum, good evening, and Happy New Year to all the participants. From today, we are starting a new module. I'm sure you all can hear me.
Ji, thank
So,
you.
this is the neuroanesthesia module, in which we have two speakers today. We'll start with the basics of neuroanesthesia, followed by the anesthesia for the pituitary surgery. So, for the first talk, we have Dr. Sayyid Farjad Sultan. And for the next one, we have Dr. Arsalan Zahid. I'm sure you all know about the Dr. Sayyid Farjad Sultan. You all are well aware of him. Um, he is one of the youngest faculty uh, who presented uh, almost throughout the country. Um, his work, his he has, he has given presentations on multiple topics. Dr. Sayyid Farjad Sultan is basically a Dow graduate who, after completing his internship at Civil Hospital Karachi, proceeded for higher education and training to Ireland. He cleared his final fellowship in 2008 from the Royal College of Anaesthesia, Ireland. Then he proceeded for a fellowship in regional anesthesia from Cork University Hospital. He was awarded CCST in 2013 and is on the specialist register. He also has a fellowship in critical care from the College of Anaesthetists, Ireland, and a PhD in training in an assessment of procedural skills required for ultrasound guided peripheral nerve blockade from National University Ireland, University College Cork, awarded in 2016. He then returned back to the Karachi, Pakistan in 2013 and joined the Indus Hospital as the head of critical care, where he helped develop uh, the critical care network. Dr. Farjad, looking for a further challenge, joined the Department of Anesthesia at Dow University of Health Sciences in the year 2019. He was instrumental in the planning and implementation of COVID ICU at Civil Hospital Karachi and was also responsible for planning and running of the standalone COVID ICU high dependency unit at the Expo Center for 2 years as a volunteer, treating near 4,000 organ failure COVID patients with his team. He is presently the chairperson of anesthesia at Dow University of Health Sciences and is also the director of the Professional Development Center at Dow University of Health Sciences, being responsible for managing of the undergraduate skill lab, American Heart Association activity monitoring of Pakistan, and Asir Rahman's Simulation Center and the CME section at Dow University with his team. He has represented Dow University Health Sciences at multiple international conferences as a speaker and at national conferences as a keynote speaker. He is a master trainer for a number of international ICU and trauma courses, as well as a trainer in all anesthesia and ICU related national conferences in Pakistan. Um, this was the introduction of Dr. Farjad Sultan. And Dr. Arsalan Zahid, he's a distinguished anesthetist with an impressive academic and professional journey. He completed his residency in anesthesia from the Indira Hospital, followed by a fellowship in cardiothoracic anesthesia at the Aga Khan University. Currently serving as a consultant cardiothoracic anesthetist at National Medical Center, Dr. Aslan has earned a reputation for his expertise and dedication in the field. In addition to his clinical responsibilities, he has conducted numerous workshops contributing significantly to medical education and professional development. His scholarly contributions include a series of publications in reputable journals as well. So I welcome both the speakers. First talk will be started by the Dr. Farjad Sultan. So before proceeding, I would request all the participants to please mute their microphone of their cell phone. And if you have any question, you can write in the chat box for the first presentation. Uh, Dr. Farjad, please.
Thank you very much, Azhar. You are too kind. First of all, thank you for the organizers for asking me to present this topic. So just the basics of anesthesia for neurosurgical patients. Um, sorry. So There are a number of recurrent elements that should be discussed before each case with the neurosurgeons, with the team, and the list is quite extensive. But bear in mind that the basics are very important. And if you don't remember too much of what it is, the norm should be maintained for the patient. The recurrent discussions starts with what the position is going to be for the patient, where the surgeons are going to be standing, because we have to keep in mind that it's not technically a shared airway, but a shared area around the airway. What are the positioning aids going to be? The use of steroids, diuretics, anticonvulsants, antibiotic, whether they will require any specific neurophysiological monitoring, and the surgeon's perception of tightness of brain. There's a huge variability and a threshold for surgeons when it comes on how tight the brain is. Some have a very low threshold, and they will say the brain is getting tight and to take whatever the actions are, whereas others will wait for a bit longer. So there's a huge variability. So there should not be a communication gap. And just to clear the point and just tell them that is this what you require, or what is it that you require? What are the objectives for the blood pressure, the PSU2, the temperature, and the anticipated blood loss, and again, the risk of air embolism, irrespective of the surgical position. So we have to remember, uh, we have a closed cranium. We have to keep in mind the ICP. We have to maintain the CPP. CPP is the cerebral perfusion pressure, which is the mean arterial pressure minus the intracranial pressure. And all this is to prevent herniation of the cranial content. So if you look at the 1, 2, 3, and 4, these are the most common ones that happen. And this is how things go. What are the clinical indicators for raised ICP? Well, in an awake patient, it starts with a headache, bit of nausea, vomiting, gets worse, blurred vision, somnolence, and extends up to papilledema. On a CT brain, one can see anything from a midline shift to obliteration of the basal cisterns, the loss of sulci gyri, ventricular effacement, and edema, which shows as hypodensities. Please remember the Monroe-Kelly doctrine that there is only a limit, and this is the purple part in between, under the 20, where the compensation occurs. But as soon as the volume of a single or multiple intracranial substance increases, after a certain point, there's a very sharp increase, which initially with focus single intracranial substances. There are four compartments, there are four things in it. In the cranium, the blood volume, the CSF volume, the cellular compartment, and the fluid compartment. If there's an injury, a neurological injury, depending on the mechanism of injury or ischemia, it's going to increase the edema. And it all increases the raised ICP, which causes a raised, it increases the raised intracranial volume, which is going to cause a raised ICP, which may cause herniation and reduces the perfusion pressure, and which again goes back to the mechanical injury or ischemia. For the cellular compartment, there are mass lesions, tumors, or even hematoma, which can be the subdural, extradural, intracranial. The blood volume is something that is relatively controllable. Again, I say relatively because sometimes it does get beyond control. With the increased area or intrathoracic pressure, it increases the jugular venous pressure, which in turn increases the blood volume. Higher PSO2, lower PaO2 increases the blood volume. And please remember, most of the anesthetics or vasodilators, they increase the blood volume, and seizure activities also tend to increase the blood volume. So there are actually four different compartments which correlate in a closed box. So one has to be very, very careful with this. So for the cellular compartment, there's surgical removal. For the fluids, intracellular and extracellular, steroids are used for tumors and are not recommended for other things. Diuretics are used. CSF can be drained. Arterial blood can be controlled, which decreases the cerebral blood flow. And the venous blood can be reduced by improving the drainage. The selection of the anesthetist is quite important. Anesthetics, analgesics, and sedatives reduce the cerebral blood flow and the cerebral metabolic rate. The only exception is ketamine. And remember, all inhalation agents cause cerebral vasodilation, halothane more than enflurane, desflurane, isoflurane, and so on. And use of nitrous oxide is not recommended at all, and it is quite a potent cerebral vasodilator. What are the factors which affect the cerebral blood flow? It's quite a significant list, some of which I have gone through, but please keep in mind the status of the autoregulation that the patient has. So the chronically hypertensive will have the autoregulation shifted to the right. So if the patient has a history of chronic hypertension, they will require a higher blood pressure to maintain the blood flows. Regarding the management of carbon dioxide, initially for hyperventilation in hours, it's fine. The CSF improves and the cerebral blood flow reduces up to the 4 to 6 hours. And then even with hyperventilation, it does tend to come back to normal and then it will overshoot. So please keep in mind that is not an absolute way of doing it. It is used more as a rescue therapy in between reaching until we have definitive therapy available. The management of arterial blood pressure is, again, there's a curve. The line is the autoregulation one. And if we don't have it, then it's going to have a direct link to the rise in blood pressure. What are the indications of using invasive blood pressure monitoring? There's a huge list of it. We can go through each one of them. And again, common sense should prevail. If you have serious concerns regarding ICP and ICP control, cite invasive blood pressure line. It will help. Regarding the positions, please keep in mind there are a lot of positional aids and support. The pins, the head holders, the Mayfield ones, when the pin goes in, it does cause quite a significant sympathetic response. So we need to give the analgesic accordingly. Keep in mind that in such positions, there is extensive venous drainage and pooling after anesthetics. So what can happen is a drop in blood pressure. So keep in mind all these things. There are different aids and supports that can be used, such as the foam head support, the vacuum mattress, the Andrews type frame, and other things. The horseshoe headdress is the most common one that is used, and it is quite helpful as well. Please, please, please keep in mind that you have to look at the pressure points throughout, once before the positioning and even after the positioning is done. Please ensure you've checked it all and documented it all. There is a risk of venous air embolism. Again, transesophageal echo, a Doppler, the drop in PaCO2, or drop change in cardiac output, a CVP, or blood pressure, ECG, again, decreasing sensitivity. What to do? First thing, prevent further injury. Tell the surgeon, stop. Flood the surgical field, cause jugular compression, lower the head. How to treat the intravascular air? Aspirate the right heart catheter if it's there. One should not be using nitrous oxide, but if it is, turn it off. 100% oxygen. You may require pressors and inotropes depending on the sheer volume of air which has gone in. And you may even need to do chest compression because it may lead to a cardiac arrest as well. Regarding the intravenous fluid management, maintain normal volemia and avoid reduction of serum osmolality. How to do that? Use isotonic solutions, Ringers, normal saline, colloids. We don't want to change the serum osmolarity too much because the brain has a high tendency to get edematous on everything. Hypothermia, for anesthesia point of view, mild hypothermia between 32 to 34 degrees centigrade. It's still a bit controversial whether to use it for routine cases, but it is used in ICU for management of the ICP. So again, a bit controversial for using it intraoperatively because it is quite difficult to monitor it as well. In emergence, everyone says there should be smooth emergence. So which actually means there should be no hypertension, no coughing or straining. So once the blood pressure starts rising, we can use labetalol, esmolol, enalapril, diltiazem, whichever is available. Regarding the coughing and straining, there's early discontinuation of the anesthetic agent. Keep in mind that one will have to bear that you don't want to turn it off too early. Otherwise, the surgeon is going to complain that the patient is moving. Using of lignocaine, 1 to 1.5 milligram per kilogram IV bolus during the head dressing time can reduce the coughing and straining, or early extubation with replacement of, or deep extubation with the replacement of the tube with an LMA. It, after good suctioning, can actually help with the coughing and straining. I'm going to touch a little bit on head injury as well, because going through the list, there wasn't much. Again, the themes are recurrent. Everything that we have gone before this, everything applies to the head injury as well as the elective patient as well. Usually, the airway is managed in the ER. If the GCS is less than 8, intubate. It's after head injury, low GCS, you need to do ICP control, you have airway protection, it's much safer. If it is greater than 8, please be aware if there's cardiopulmonary dysfunction, or patient is uncooperative, or you need to do some diagnostic procedures, you may need to intubate. There are no firm, fixed, fast rules. Uh, Generally speaking, the intubation, consider all head injury patient as full stomach, having uncertain C-spine, uncertain airway, expect blood in the airway. There may be laryngeal injury, again, head injury, head, say, upper airway. We don't know the volume status. The patients are usually quite uncooperative and combative because they're quite confused. There may be hypoxemia, or there is going to be increased ICP, which leads to uncooperativeness and combativeness. There is no correct way, there is no best way. Follow the APCs of resuscitation. An intact airway on a dead patient is of no particular use. So please be safe. Again, the head injury patient, beware. It should be treated until proven otherwise and documented. An unstable C-spine. Remember, 2% of these C-spine injury are due to blunt trauma. Traumatic brain injury is there. Less than 8 GCS, consider it as an unstable C-spine. Hypnotic relaxant, direct laryngoscopy, manual inline stabilization. You need to do these, be safe, and get a definitive airway as early as possible. It's not something that you let a junior do. It should be an experienced person doing it, and it should be at the first go. Anesthetic technique, so generally speaking, craniotomies are done for evacuation of hematoma. It can be subdural, epidural, or intracerebral. All intravenous anesthetics can be used except ketamine. Having said that, be aware of ketamine. You may need to use it, but avoid using it. And all inhalation agents are vasodilators. So again, keep in mind the same rules apply for elective as well as emergencies. IV access is there, arterial line, whether to do it pre-induction or post-induction is a decision that you'll have to take there and then regarding the patient's condition. Do cite a CVP line because these patients tend to have cardiovascular instability, and you may need to run inotropes, or you require volume resuscitation as well. For the cerebral perfusion pressure, there are 3 sort of protocols which are out there. The Birmingham protocol, it uses the concept of induced hypertension and ICP control, and it assumes that there's preserved autoregulation. The Loon protocol uses dehydration and hyperosmolality and has a cerebral perfusion target of 60 to 70 millimeter mercury. Then there's the Edinburgh protocol, which is for low post-injury cerebral blood flow. It assumes impaired autoregulation. The cerebral perfusion pressures are 70 millimeter mercury, and they recommend monitoring of CPP via the jugulus venous oxygen saturation. So it doesn't actually matter. It depends on what the protocols are used in your ICU and which ones your neurosurgeons are most comfortable in. Hypocapnia is not recommended by Brain Trauma Foundation for head injury patients. There should be a normal range of carbon dioxide. A bit on the lower side of normal is acceptable, but hypocapnia should be avoided. Fluid management, again, prevent profound reduction of colloid oncotic pressure, maintain normal volemia. So if a head injury patient comes in, there's primary survey, secondary survey, so you're looking for occult blood losses as well. So the volume should be maintained. Please keep in mind that using a lot of normal saline not only raises the sodium, but raises the chloride level as well. And the last thing you want is to cause hypochloremic metabolic acidosis, and that does happen. So after 2-3 liters of normal saline, just start monitoring the chloride levels as well. Regarding the jugular venous oxygen saturation, it should be between 55 and 75, and less than 50% for 5 minutes is defined as jugular desaturation, and you need to start working on the oxygen delivery. But again, definitive recommendations are not there, and further research needs to be done. Hypothermia for head injury patient is a rescue technique. So if there is some brain edema happening and there's a bit of time before reaching the theater or going for a CT, you may induce hypothermia. Rescue technique, it is not definitive treatment at all. The last slide is of CSF shunting, where we remove the CSF. The catheter is sited via a burr hole. Now, this can end up either as a EVD, extraventricular drain, or in long-term patient, it ends in the reservoir. The reservoir is placed subcutaneously adjacent to the burr hole, and then the subcutaneous tunneling into the peritoneum. Anesthesia is required. Otherwise, the subcutaneous tunneling causes quite a significant sympathetic response. And please know this, that irrespective of whatever it is, be the calm in all of this. Thank you very much. Azhar, over to you.
Thank you, Dr. Farjad, for giving such an insightful conceptual talk. So there are two questions, but those two questions are related more towards the practical conduct. So that would be answered after the second talk. So if anyone
Sure.
has any question, please ask, or otherwise we will move to the other presentation by Dr. Zahid.
Azhar, can I comment on the presentation? Just I want to comment on the 2 points.
Yes,
I'm
sure.
Dr. Faraz.
Okay, yeah,
So,
okay. Dr. Faraz is with us. He's the consultant anesthetist at Arsalan University Hospital, and he started the module. He's a module coordinator as well, neuroanesthesia, and he started the awake craniotomy service in Arsalan University Hospital as well. Yes, please, Dr. Faraz.
so thank you, Farjad, for a wonderful presentation. So I just want to comment on the two things. So the one is the use of nitrous oxide, and second is the utility of scalp block. So as Dr. Farjad was saying, though it's a bit contraindicated the use of nitrous oxide, but if we see and go to the literature, so if we'll keep the map between less than 1, and if we'll keep the regulation, outer regulation would be there. It means like if you are maintaining the map, if you are keeping your end tidal CO2 between 30 to 35, so the use of nitrous oxide is not that much harmful, provided you are not dealing with a scenario where massive raise in ICP would be the case. So in those circumstances, you can avoid using nitrous oxide. But for the rest of the cases in which, especially I'm talking about the tumor craniotomies, so the use of nitrous oxide would be safe, provided you are keeping your MEG less than 1, you are maintaining your blood pressure, and you are keeping your end tidal between 30 to 35. Similarly, recent study, the Enigma trial, if you go to that trial, though it was not conducted primarily in the neurosurgical patients, so the subset analysis of that trial in neurosurgical cohort said the nitrous oxide is quite safe. And the second point is, my point is that as Dr. Farjad was saying, the stimuli of the pins, Mayfield pins, it's the worst stimuli I've ever seen in the anesthesia. So I think the take-home message from my side to the audience, to the participants, residents, and the faculty member is to use the scalp block. And scalp block in this scenario is magical. So once you use it, you will be remember so how you are going to blunt that response dramatically without using any other sort of drugs. So those were the two comments from my side. And thanks, Farjad, for a wonderful presentation and basic concepts. It's very important you delivered, at the start of your talk that things would be recurrent and one has to be logical in terms of providing care to neuroanesthesia patients. Thank you.
Thank you very much, Faraz, for those comments. And again, yes, scalp locks I did not mention because I think I left it to you for the victory, not me to mention. But yes, they are quite important. Again, for the regarding nitrous, I did say it's a bit controversial. It's if you can avoid it, avoid it. But yes, it has been used. I have used it, but I've stopped using it for the neurosurgical cases. But anyways. Thank you very much for those lovely comments.
Thank you, Dr. Farjad. Thank you, Dr. Faraz. Dr. Arsalan, you may start now. Yes, Dr. Arsalan.
Am I audible?
Yeah, we can hear you now.
Oh, thank you very much. Thank you for having me there. So, in this part of the session, I will be discussing the anesthesia consideration for patient undergoing pituitary tumor surgery. I would like to extend my thanks to Dr. Farjad as his previous talk on basics of neuroanesthesia has made my work much easier. Given the time constraints, I will be covering the key point concisely, focusing on most critical aspect of the anesthesia management in these cases. As we begin, it is essential to recognize the central and important role of pituitary gland in endocrine function. The
Okay,
pituitary gland.
sorry, Arsalan, to interrupt you. Please, could you enlarge it, your presentation? Your slides not very much visible.
It is enlarged now.
Okay, actually, it's in the grid format right now.
Now,
No, not as yet.
it is full
Okay, that's
screen
fine.
from my side.
Okay,
It's
yeah,
full
okay,
screen from my side.
you may continue it.
Okay. The pituitary gland located at the base of the brain beneath the hypothalamus is known as master gland due to its crucial role in regulating various hormone systems. It secretes hormones such as growth hormone, ACTH, TSH, FSH, and luteinizing hormone, which influence critical functions like growth hormone, metabolism, reproduction, and stress response. Pituitary tumors are relatively common, accounting for approximately 10 to 15% of all the intracranial tumors. Given the central role of pituitary in regulating critical endocrine functions, the presence of a tumor can have significant systemic effects. The pituitary gland consists of two histological distinct parts, the adenohypophysis and neurohypophysis. The adenohypophysis, which is large, vascular, and pink, is responsible for secretion of hormones like growth hormone and ACTH. The neurohypophysis, which is smaller, less vascular, gray or white in color, and stores hormones like vasopressin and oxytocin. Immunocytochemical techniques have become the standard for identifying specific pituitary cell types. These include somatotrophs, which produce growth hormone and covers the major portion of the gland. Prolactin producing lactotrophs, ACTH producing corticotrophs, thyrotrophs, and gonadotrophs. Additionally, there are null cells which do not produce any identifiable hormone. Most pituitary tumors arise from the anterior part of the gland and typically resembles the normal tissue, with the majority being benign adenomas. This is very important to note. The incidence is about 200 per million people. Interestingly, pituitary adenomas are found in 10 to 27% of post-mortem examinations, highlighting their role unnoticed presence. Pituitary tumors are classified into three main categories: benign adenomas, invasive adenomas, and carcinomas. Additionally, pituitary adenomas can further be divided into non-functioning tumors, which do not secrete hormones, and functioning tumors, which produce hormones, leading to specific clinical syndrome based on the hormone they are involved. Radiologically, pituitary tumors are often classified using Hardy classification and NOS grading. Hardy's system focuses on tumor size and its relationship to Coelotertia, classifying tumor from intracellular to large invasive masses. The NOS grading system evaluates the degree of tumor invasion into cavernous sinus, with high grades indicating more extensive involvement, which is crucial for surgical planning and prognosis. Pituitary lesions can present in several ways, including hormonal hypersecretory syndromes, where tumor overproduce hormones, leading to conditions like Cushing's disease and acromegaly. Mass effect, where the tumor compress surrounding structures, causing symptoms like visual disturbances or headaches. Incidental findings, where the tumors are discovered unintentionally, often during imaging for other conditions. Patient can also present with non-specific symptoms such as fatigue or vague endocrine imbalances, which can be harder to diagnose. Type of the hormone hypersecretion and associated pathologies include growth hormone excess, which cause acromegaly in adults, or gingitism in children, leading to abnormal growth of tissues, particularly in the hands, feet, and face. Prolactin excess, hyperprolactinemia, causing symptoms like lacturia, amenorrhea, infertility. Corticotropin excess cause Cushing's disease, characterized by excessive cortisol production, leading to weight gain, hypertension, and skin changes. Thyroid stimulating excess causes hyperthyroidism, can lead to symptoms of increased metabolic rate, including weight loss, palpitation, and heat intolerance. So all of these symptoms are very important when we are assessing these patients in our pre-op readings. Mass effects are commonly seen in non-functioning macroadenomas, which are larger than 1 centimeter. These tumors can compress surrounding structures such as optic nerve and chiasma, leading to visual disturbances, particularly bitemporal hemianopia. Other complications of mass effect include pituitary apoplexy, a sudden hemorrhage or infarction of pituitary gland, and hydrocephalus, resulting from obstruction of CSF flow. So the question arises, what are the primary goals of pituitary surgery? So the answer is, the primary goal of pituitary surgeries are to remove as much as tumor as possible, avoid additional neurological damage, and preserve healthy pituitary tissue to maintain normal endocrine function postoperatively. Anesthesia concentration can be broadly categorized into general and specific categories. The general concentration are focuses on patient's overall health status and external factors, while the specific concentration are closely related to pathology and surgical procedures. This distinction ensures a comprehensive and tailored anesthesia management. General concentration include tailored anesthesia management to patient's age, considering physiological differences, for example, pediatric or geriatric consideration, consider gender-based differences in drug metabolism, hormonal fluctuation, and anesthesia responses. Take into account any pre-existing medical condition and their impact on anesthesia management. The timing of the procedure may influence fasting, metabolic status, and fluid management. Adaptation of anesthesia management to surgeon's approach and technique. Specific concentration Characteristics of condition, for example, tumor size, location, hormonal effects, and how they impact the anesthesia care. Perioperative consideration assess the patient's general health and the plan to specific needs for the surgery, such as positioning, airway management, and potential complication. And in the last, prepare for both anticipated and non-anticipated complications after surgery and or during surgery. Preoperative assessment. The preoperative assessment of the pituitary tumor surgery should focus on three main aspects. Evaluation of signs of hypo or hypersecretion of pituitary hormones such as acromegaly, Cushing's disease, or prolactin excess. Assessment of the patient's endocrine function to guide perioperative management and anticipate potential hormonal imbalance. Assessment of any mass effect on the adjacent vital structures such as optic nerve or chiasma, which may present as visual disturbances. Structural and functional airway assessment. Acromegaly presents several airway challenges due to structural changes. These include prognathism, macroglossia, which can lead to difficulty with intubation and airway management. Thickening of laryngeal soft tissue and vocal cords, making the airway more prone to obstruction. Reduction in size of laryngeal aperture, which may complicate the airway access. Hypertrophy of periepiglotic folds, which can further narrow the airway. Recurrent laryngeal nerve palsy, leading to potential voice change or airway complication. And large thyroid is approximately 25% of the case, which can complicate visualization and intubation. These factors highlight the importance of thorough airway assessment and preparation for potential difficulties in managing the airway. Even patients with Balam-Patti 1 or 2 can present with difficult airway due to other factors such as anatomical changes for acromegaly or small effect for pituitary tumors. It's essential that difficult airway trolley be checked and kept ready prior to induction and intubation to ensure quick access to airway management tools if needed. Additionally, postoperative airway obstruction is a concern, especially in patients with obstructive sleep apnea. Close monitoring and management may be required to prevent complication. Patients with pituitary tumor, particularly those with endocrine disorders like acromegaly, may have associated cardiovascular issues. These include ventricular hypertrophy due to long-standing hypertension or increased cardiac workload. Coronary artery disease increasing the risk of ischemic events, arrhythmia or conduction disturbances, valvular heart disease often due to increased growth hormones, cardiomyopathy, congestive heart failure, pulmonary hypertension, and core pulmonale related to respiratory or vascular complication. A thorough cardiovascular assessment is critical to identify and manage these potential issues, ensuring optimal perioperative care. A neurological evaluation should focus on raised intracranial pressure, which may present as headache, nausea, and altered consciousness. Hydrocephalus, visual field defects, serum electrolytes, and serum and urinary osmolality, which may be altered by hormonal imbalances or pituitary dysfunction. Imaging to assess the size of the tumor and its extension, which is crucial for surgical planning and identifying any compression or the surrounding structures. Assessment of other systems include thyroid function test, important for assessing the potential thyroid dysfunction, which can be influenced by pituitary tumor or treatment. Patients with Cushing's disease have fragile blood vessels due to long-standing steroid access. So careful planning for vascular access is essential, or we may need central line for this. along with its key features such as osteoporosis, easy bruising, truncal obesity, myopathy, and gastroesophageal reflex requires attention during perioperative period as they can influence the drug absorption, recovery, and overall management of the patient. There are three main surgical approaches to pituitary gland: transsphenoid, transethmoid, and transcranial. The most common used method is transsphenoid for pituitary surgery, which can be performed by sublabial or endonasal route. Transethmoid approach is less commonly used, but it provides an alternative route through ethmoid sinus for assessing the pituitary region. Transcranial approach used for larger or more invasive tumors. Patients with pituitary tumor are often multiple medication. Pre-medication and drug therapy should be carefully managed according to patient's current medication and underlying condition, and should always be guided by institutional guidelines to ensure safety during anesthesia. So what are the aims we want to achieve during anesthesia of these patients? Perioperative hemodynamic stability, maintenance of normal intracranial pressure, brain relaxation, renal protection, rapid response to intraoperative complication, smooth and rapid emergence and recovery, and management of postoperative hormonal disturbances and complications. Now, we'll be discussing what are the aims we want to achieve during induction of anesthesia. We would like to have rapid and smooth induction, ensure a swift and comfortable induction to minimize patient distress and maintain stability, avoid increase in ICP and hypoxia at any cost, secure airway as early as possible. So how these aims can be achieved? Ensure adequate pre-oxygenation before induction to reduce the risk of hypoxia during the procedure. Opioid and benzodiazepines to provide anxiolysis and pain relief to the patients. Use propofol or etomidate for a smooth and controlled loss of consciousness, avoiding hypotension. Administer agents like rocuronium or succinylcholine to facilitate endotracheal intubation and muscle relaxation. Maintain stable blood pressure and avoid large fluctuation to ensure patient safety. So what are the aims we want to achieve in the maintenance phase of the anesthesia? Ensure hemodynamic stability, prevent increase in ICP, and ensure adequate muscle relaxation to facilitate optimal surgical access, especially for delicate procedures around the pituitary and surrounding structures. So two manuals which I am discussing here are techniques used to facilitate surgical visualization during the pituitary surgery. Both of these manuals are highly individualized based practice, particularly in complex neurosurgery procedures to improve surgical outcome and to ensure better visualization. These advantages are clear in terms of facilitating tumor access, though careful monitoring of the patient's hemodynamic status is critical to prevent complication. Lumbar spinal drain is typically inserted preoperatively at L3-L4 space. A small volume of normosaline 5 to 10 ml is injected into subarachnoid space, creating a pressure effect. These pressures help to push the suprasellar extension of the tumor into the surgical field, providing surgeon with better access and visibility during minimal invasive surgeries. Permissive hypercapnia. By intentionally increase the PCO2 to around 60 mm of mercury, there is a rise in intracranial pressure for a short period of time, which can displace the pituitary tumor into the infracellular space. This manner helps to shift tumor and enhance the accessibility during the surgery. However, Permissive hypercapnia carries risk including hypotension, tachycardia, and potential imbalance in oxygen demand and supply to the myocardium. These risks need to be carefully managed during the maneuver. After the surgery, ensure the throat pack is removed to prevent airway obstruction and discomfort. Carefully clean the throat and check for any blood and fluid trickling down from the nasopharynx, which could indicate the bleeding and leaking. This is very important. Patient should be extubated only when fully awake with the complete return of productive airway reflexes to ensure safe recovery and minimize the risk of aspiration. Mask ventilation may be difficult post-operatively, particularly in patients with acromegaly or those with airway challenges. These patients may need to be instructed to breathe from the mouth to maintain oxygenation until they can breathe effectively on their own. Continuous monitoring of the patient's vital signs, including heart rate, blood pressure, oxygen saturation, respiratory rate, to detect any early sign of complication. Post-surgery, patient may require hormonal supplementation due to pituitary dysfunction, especially if the gland has been affected by tumor or surgery. Monitor and adjust hormone levels as needed. Careful management, fluid balance, as patient may be at risk of diabetes insipidus or other electrolyte imbalances post-operatively. Close monitoring of input and output and electrolytes is crucial. Ensure effective pain management to keep patient comfortable and facilitate recovery. Adequate analgesia will also help to minimize complication related to stress response. Continue to ensure patient is adequately oxygenated and that the airway remains secure postoperatively. Any signs of respiratory distress should be addressed promptly. If the patient develops difficulty in breathing, consider possibility of blood or CSF leakage and trickling into the airway, particularly if they had a transsphenoid approach. This required immediate attention to prevent further complication. Optic nerve and abducens nerve are located near the pituitary gland and can be affected during the surgery. Frequent assessment of level of consciousness, eye movement, visual field, and visual acuity is crucial to detect any neurological changes. Any deterioration in function should promptly, immediately discuss with the surgeon and consideration for radiological investigation or re-exploration if needed. Nasal CPAP is contraindicated following transsphenoid surgery due to risk of tension pneumocephalus, which can lead to significant complication. Opioids are very effective for management of postoperative pain. However, multimodal analgesia is preferred for optimal pain control while minimizing opioid use and potential side effects. So now we will be discuss the anticipated neuroendocrine abnormalities in postoperative period. Diabetes insipidus can occur after pituitary surgery, particularly if more than 80% of vasopressin secreting cells are destroyed, leading to significant fluid deficit and imbalance. Diagnosis can be made if plasma osmolality is greater than 295 and urine osmolality is less than 300 milliosmol per kg. Urine output greater than 2 ml per kg per hour is a key indicator as the body excretes large amount of diluted urine. The treatment of choice for diabetes insipidus is the use of intranasal desmopressin, which helps regulate water balance and reduce urine output. Another option is vasopressin, given subcutaneously to help to control water retention. It is critical to monitor plasma sodium and osmolality to avoid complications like hyponatremia or dehydration. Intravenous fluid is provided for maintenance of hydration. The fluid volume is adjusted based on urine output, typically targeting 2/3 of previous hour's urine output. Syndrome of inappropriate ADH can occur as a result of over-enthusiastic use of desmopressin, which lead to excessive water retention and dilution of sodium in the body. Diagnosis can be made if the serum sodium level is less than 135 and urine sodium is greater than 40 milliequivalent per liter. Treatment includes fluid restriction and sodium supplements to restore normal levels and correct the electrolyte imbalance. After pituitary surgery, particularly transsphenoid procedures, there is a risk of CSF leakage due to tear or breach in the dura mater. This can result in CSF leakage into nasal cavity or sinuses. Patient may present with symptoms like clear watery nasal discharge or sensation of fluid trickling down the back of the throat. This is typically more noticeable when the patient is upright or coughing. The main treatment of CSF leakage is re-exploration of the surgical site to identify and repair the source of leakage. The autologous fat packing technique involves using patient's own fat to seal the defect in the dura and prevent further leakage. This is often combined with nasal packing to ensure adequate support and integrity of the seal. If CSF leakage is not managed appropriately, it can lead to complications such as meningitis and persistent CSF fistula. After pituitary surgery, steroid supplementation is necessary to replace cortisol, as the pituitary may not signal the adrenal gland effectively due to surgery-induced damage. Surgery can impair the HPA axis, causing adrenal insufficiency. Without adequate cortisol, the patient is at risk of adrenal crisis. Steroids are initially given at higher doses and then tapered down as the pituitary function recovers. Regular monitoring of the cortisol level is essential. Some patients may require long-term steroid therapy if pituitary function does not fully recover. Thank you very much.
Thank you, Dr. Zahid. If anyone has any question, please write down in the chat box. Meanwhile, I would like to request Dr. Faraz Shafiq to please give some insight regarding the talk.
Okay. Thank you, Dr. Azhar, and thank you, Dr.
Please
Arsalan, for a
share
wonderful.
any updated guideline if it is for the pituitary tumor.
Okay. Okay, so thank you, Dr. Arsalan, for a wonderful presentation. I think you have covered most of the relevant aspects. So two or three things which I want to share with the audience. I think it might be useful or might be you people are using in your clinical setup. So assessment of acromegaly patients. So especially if you are dealing with a scenario where patients would be having obstructive sleep apnea, overweight. So as Dr. Aslan was saying, so don't take airway lightly. So even with the straightforward airway, you will be ending up in having, difficulty in intubation. So for those kind of scenarios, my opinion is to use the regular use of video laryngoscope. So that use of video laryngoscope would give you an idea to start up with the airway, and that would be really useful at the time of extubation. Besides, it's also very important because most of these cases being done in under transsphenoidal approach. So better to discuss with your patient operatively that their nasal passages would be blocked with the packing, so they have to breathe through a mouth. So for those particular scenarios, what I found very useful that TIVA-based anesthesia would be really useful in terms of rapid awakening, in terms of improving their recovery profiles, in terms of dealing with the airway where patient would be having sleep apnea and obstruction, nose would be blocked with the packing. So for those kind of patients, they behave very well with the TIVA technique. It's my personal opinion. So, and besides, it's also very important for, say, if you are dealing with the So it's, as Dr. Arsalan was saying, there are three kinds of tumor: microadenoma, macro, or you might be dealing up with the craniopharyngioma. So please don't take craniopharyngioma lightly. So with all sort of craniopharyngioma resections, especially I'm talking about the pediatric patients, or those patients who have got massive resection of that craniopharyngioma, you'll end up in having lot of electrolyte and fluid imbalances in the post-operative period. So for those patients, better to have a strict input-output control, and definitely the need of invasive monitoring, especially the CVP. So don't take those patients lightly. So yeah, that was my opinion. Thank you, Dr. Azhar, and thank you, Dr. Aslan and Dr. Farjad, for a wonderful presentation.
Dr. Faraz. So there is a question asked by Dr. Jamshed Khan. Is there any role of dexamethasone preoperatively to reduce the brain edema and craniotomy, Dr. Arsalan?
So as per the researches, there is no any research in my side which compared the dexamethasone particularly in this population, neurosurgery population. But as we know, dexamethasone has some effect, has some role in patient in managing postoperative pain or intraoperative pain in multimodal anesthesia.
No, sorry, Dr. Azhar.
So,
Can I reply to it?
yeah, please, Faraz, please go ahead.
Sorry, Farjad, you can speak.
So I was just saying that steroids are indicated for edema, which is linked with tumors, or tumor edema, and their steroids do not have a role in traumatic brain injury at all, or edema related to traumatic brain injury. The recommendations are not there for using steroid for brain edema with traumatic brain injury, but yes, steroids have been used to reduce tumor-linked brain edema. Faraz,
Yes,
please.
yes, absolutely right. So its role is very well defined, and they are pretty efficacious in the brain tumor setting, where the mode of action, as Dr. Farjad was saying, it reduces the tumor side, and especially the mode of action is free radical scavenging from the peri-tumor area. So efficacy is well established in that kind of scenario, but not for the head injury. Yes.
Thank you. So if there's any question, please ask. Meanwhile, I would request Joint Secretary of Pakistan Society of Anesthesiologists, Karachi chapter, Dr. Sayyid Talal Ahmed, please come for the comments.
Thank you, Dr. Azhar. Thank you, Dr. Faraz. And thank you, Dr. Fajad and Dr. Arsalan, for such an engaging and insightful lecture. I truly appreciate the effort that you both of you has put in making the lecture so clear and interesting for all of us. And Dr. Fajad, it's always a pleasure to learn from you, sir. Thank you so much, Dr. Fajad and Dr. Arsalan. We are truly honored to be hearing you both. Thank you so much.
So
Thank you, Azhar. Thank
we
you,
are
everyone.
honored with the presence of Dr. Professor Akhtar Wahid Khan. Sir, if you could please give some comments. Could you please unmute your mic and give some comments? Yes, Dr.
Yes, I'm there. Yes, thank you very much. Well, the first speaker, I know him for ages. He has been there. He has given very good presentation, very excellent presentation about head injury. But unfortunately, I don't know, Farjad, I was late in getting the site. But did you mention about the head injury prevention strategy so that people can talk to those people? I don't know
Sir,
if you did it or
traumatic brain injury would be covered in some other talk. This was basically for the pituitary adenoma, and first talk was regarding the physiology.
all right.
Sir,
Now, regarding
Assalamualaikum, sir. Sir, thank you very much. Sir, sorry, sir, आपकी बात interrupt कर रहा हूँ. The first talk was the basics of anesthesia for neurosurgery. the neurophysiology, and I just touched a little bit on the head injury and traumatic brain injury patients and the mode of anesthesia for them, and just the particular concerns. So the biggest thing that I said was that everything, more or less everything, is a recurrent theme. So we should be asking the same questions every time to the surgeons, which includes the positioning, the tightness of brain, what medication they want to use, what are the goals and targets. So that's it was more on the physiology point of view.
That's right. My question to the next speaker is, how do you produce pervasive hypercapnia in your patients?
So, sir, it was in the literature where the
Yes.
individualized practice. It is the individualized practice. It is not practice in the general aspects. But by seeing the untitled CO2, we can go to a higher level of the untitled CO2 so that we can increase the PCO2 in the patient. So we can achieve a permissive hypercapnia level of, as literature says, 60 millimeter of mercury.
Yes, and your objective is to produce vasodilatation, perhaps.
To increase the intracranial pressure, yes, to vasodilate and increase the blood volume in the skull cavity. So it increases the ICP and it pushes the supracellular extension of the pituitary tumor to the infracellular. So minimal invasive, when we are doing minimal invasive surgeries, so visualization is improved.
Yeah, so can I comment on it, Dr. Sir?
I thoroughly enjoyed neurosurgery, these lectures by both of you, and I have not done any neuroanesthesia for the last 25 years, 20 years now, but thoroughly
Thank you.
enjoyed.
Yeah. Thank you, Dr. Akhtar. Dr. Faraz, you want to give some comment?
So I think that this strategy of doing permissive hypercapnia would be really dangerous. I think it's pretty anecdotal, as Dr. Arsalan was saying. I think take-home message from this forum should, and especially in the scenario where we are working, we have got limited monitoring for our cases. Especially, I'm talking about neuroanesthesia cases. I think for those kind of cases, better to avoid it because we don't know, and it's pretty anecdotal. So most of the time, surgeon used to put lumbar drain, and I think that would be enough. So the take-home message is that one should not try it with the kind of monitoring we'll be having. So that is my message.
Thank you. Dr. Leena Ayub is also with us. She is the chairperson of the Ghurki Trust Hospital, Lahore. She is doing a wonderful work not only in anesthesia but in pain management as well. I will request Dr. Leena, could you please give some comments? Dr. Leena, are you there?
Thank you very much. It was indeed a pleasure listening to both the speakers. We enjoyed the basics and the advanced, especially the pituitary one. Thank you very much. And there was a very good take-home message and how to be very careful and
MashaAllah, yes.
Okay, sorry. There is, I think, some connectivity issue. So meanwhile, there is a question, Dr. Zahid. Dr. Jamshed Khan has a question. What should be the mean arterial pressure targets in raised ICP, but we don't know the exact value of ICP?
May I answer, sir?
Yes, sure, please.
In context to the raised ICP, the target CVP is typically aimed to 60 to 70 millimeter of mercury for adults. This ensures the adequate perfusion and potential risks of increased ICP. So we need to know that we always target for CPP. As Dr. Farjad Sultan has discussed earlier, that we have to target the adequate CPP, which is cerebral perfusion pressure, which is as Dr. Farjad Sultan has told earlier that it is equal to mean arterial pressure minus ICP. So if we don't know the exact ICP, so we can target the higher targets of the MAP or CPP, 70 millimeter of mercury.
Thank you, Dr. Arsalan. So with this, we come to the end of this today's session. Thank you to all the participants, and I'm thankful to all the presenters. We
Thank
will
you, Azhar.
we will meet again in the next topic. Thank you.